Good afternoon, everyone. It has entered the afternoon, so I can say that now. I'm going to be talking about dementia care mapping in mental health wards. There we go. So I believe there's a poll to start this session, just asking you about dementia care mapping. So I don't know if that can be put up. Like I said, my name's Ian Davies Abbott. I'm a lecturer in mental health and dementia at Bangor University, and also a member of CADR as well. Dementia care mapping is something you may have heard of, and that's what this poll's about. Just to say, have you actually heard of dementia care mapping? Some of you might even be dementia care mappers, and some of you may never have heard of it at all. So we'll just see maybe if we can get those results up and see what people actually know about dementia care mapping, or whether they've actually heard of it at all. But what I will do is I will actually describe what dementia care mapping is before I go into actually some of the details of this study. And I think that's useful, not just because of the study that I'm talking about today, but also because dementia care mapping is something that's actually going to be becoming much more frequently used across Wales, because some of the standards that are now being published. So about half and half. Some people have heard of it, some people haven't. So not to worry, because like I say, I will be going into detail about what this actually is. The project that I'm talking about today is actually about dementia care mapping when it's actually used in older persons' mental health wards during the COVID-19 pandemic. Because during the pandemic, there's been an unprecedented challenge for people working in older people's mental health care. And there's been a need to change practice, to mitigate for things like infection prevention measures, and also to compensate for the fact that families haven't been able to visit. So a lot of the national and international guidance around working with people with dementia in a lot of care settings, including mental health wards, has tended to focus more on physical care and physical protection, which is understandable considering the dangers to that cohort. But actually, sometimes we have to think what's happening holistically. And there seems to be an intuitive belief that because visitors are restricted, and because of PPE, and because people have, let's say PPE, people look, the face is covered, there's social distancing, that actually we can't give that same level of holistic care. We can't give that psychosocial care, which is actually crucial to actually caring for people living with dementia, is in terms of actually our priorities in terms of typical mental health care would be psychosocial provision. But we're now being led by almost a physical agenda because of the nature of the pandemic and the care restrictions that we're under. Now, it's really hard at the moment to get into services, whether it's a care home, whether it's a ward, to actually see what's going on. So because obviously with social restrictions, asking, can I do research in a mental health ward is not something that's very simple to do. What we got this data from was actually the audits that happen as part of the routine within one of the Welsh health boards. And they said, they were happy for us to include this, to look at it, to see what was the impact of these restrictions on well-being in those settings. And I have to acknowledge two nurses who were key to both the data collection and the analysis, and that was Sean Page and Adrian Jones. I guess, first of all, we have to say, okay, well, what actually is dementia care mapping? What is that? Okay, it doesn't seem to be moving for me. Okay, so dementia care mapping, it's an observational tool. It's a way to see actually what's happening in a care environment, but the idea being that you see it from the eyes of the person living with dementia. For many people, we can just ask about how their day is, how they experience things. But for people who may be in the high and moderate and severe stages of dementia, that might be more difficult for that person. And actually what Tom Kitwood did is he started developing dementia care mapping in the early 90s to actually use it as an attempt to actually take the standpoint of the person with dementia and say, okay, what's actually happening for that individual? It's very much focused on this idea of person-centered care. And I'm also always a little bit loath about that idea of of person-centered care simply because it's an overused term that we seem to hear for absolutely everything. But Kit was very precise in what he meant by person-centered care in dementia. He said that person-centered care was about maintaining the personhood, maintaining who that person is in the face of what's actually happening to them due to their dementia. Oops. Oh, there we go. So why is it important in Wales at the moment? Well, it's always been important. Like I say, it's been around for 30 years, but it's actually appeared now in the Dementia Action Plan for Wales 2018 to 2022. And it's saying, you know, we need to expand the use of dementia care mapping. It's something that we had to embed in our practice, embed in not just mental health practices, but in all practice where people with dementia are actually being cared for. And only a couple of weeks ago, it's appeared again as Standard 16 in the All Wales Dementia Care Pathway of Standards to say, you know, organisations that provide intensive dementia care should actually use dementia care mapping as a framework to actually support the provision of person-centred care as well. So it's something that we're going to hear a lot about in Wales over the next few years as well as it becomes embedded. So what is it? Like I say, it's an observational tool, and the things that are collected, the things that are observed, first of all, there are behaviours. So what is the person actually doing? And you might, depending on what you're using the tool for, it might be to help with your care planning, it might be to help to understand whether an intervention is working for someone, but it might also just to be to understand the culture of care on a ward, to understand what actually happens in a care setting and how the staff are creating this culture of care. But one of the parts of data that's collected is this thing called behaviour category codes. And it's simply the case of no matter how many people you might be looking at that time, is saying over a period of a time frame of which is about 5 minutes, what's the dominant behaviour? And people over 5 minutes do lots and lots of behaviours. It's much easier if you were mapping someone on a Zoom because they're literally just watching or talking, so you'd be able to do that rather easily. But for people who are actually active and moving around and doing different things, people engage in lots of behaviours over 5 minutes, and there are lots of rules to actually follow. You need to go on to be an official kind of trained mapper to do this kind of work, to actually understand, okay, well, what is the dominant behavior? What is actually the important behavior that we can tell us more about that individual's experience? And after 5 minutes, you'll have, you know, one behavior category code. It doesn't tell you a great deal, but when you start to map over maybe 6 hours or even longer, you start to get a picture of what was the behavior of that individual over the day. Again, the codes are great, but it doesn't stop the narrative being important and actually seeing things more from actually what did actually happen rather than just seeing a lot of alphabetical codes. At the same time as that's happening, there's also the need to actually say, okay, well, by whatever behavior that is, how engaged or how happy was that person about it? So you'll also get this kind of this measurement, which has a range from +5 to -5, that says, okay, well, what is the person's mood during that period of time? So is the person very happy, which might be +5, and when we say very happy, we mean kind of the happiest that person could ever be, or are they going all the way down to -5, which would be very distressed and the unhappiest that person could be? And in terms of engagement, you might see someone who is combing their hair, but isn't particularly too engaged with it. It's just they're just doing it because it's just part and parcel of their routine and not really taking much interest in it. Or you might see someone brushing their hair that actually is very absorbed in that activity and really engrossed. And those values are judged on those things. Now, you'll usually have more than one mapper, and the idea of that, of course, is that actually to make sure that people get the same results. It's not a subjective tool. It's not something that actually, once you're trained in it, that you should get different results from everyone else. There's a case of inter-rater reliability, where people map over periods of time and make sure that they get the same results. And that's the way to actually make sure that what you're collecting is actually robust information and not just a subjective decision based on the person's who's mapping their own individual beliefs. The final thing that's collected, which is very important, is actually the behaviors that happen to the person that maybe enhance their personhood, but also maybe the behaviors that actually undermine their personhood. And what Kitwood calls these, when you read things like Dementia Reconsidered, he calls these things like positive person work, the positives, the things that help that person's personhood. In mapping, they're called personal enhancers. And the things that undermine personhood are malignant social psychology. These are personal detractions in dementia co-mapping. And what Kitwood said is when we see things like personal detractions or malignant social psychology, he was saying, you know, those things don't happen because caregivers are horrible people who are trying to attack someone's personhood. And often these things occur because actually people don't have any malicious intent. They're not trying to cause harm, but actually it's because sometimes they just don't know any better. And this is the idea of actually understanding the culture of care, that sometimes people do things because they think it's the right thing, it's the way they've been taught, rather than thinking actually, should this be challenged? And that's one of the reasons why things like malignant social psychology and personal detractions happen, because if practices can't be challenged or they're not challenged, you'll see that becoming part of the care culture. And that can be something as simple as, I mean, I can think of occasions where maybe I've started work on a ward or in a care setting, and someone's asked me for a cup of tea. You know, one person who I've been working says, oh, can I have a drink? And I'll go to the kitchen to make the drink. And when I walk in, someone says, what are you doing? And I say, I'm just going to make someone a drink. And they say, oh, no, you can't do that. It's not 11 o'clock yet. It's not time for drinks. And you think, well, surely the person's thirsty. You can make a drink. But that's part and parcel of a culture of care, that things become so routine that actually you can't go away from that. When actually it would be easy just to challenge it and say, actually, let's go and make sure that the person gets what they need. Let's make sure the person's asking for something and they need it. Other times it happens because it's a defensive reaction by caregivers, that actually sometimes people don't feel that they're in control. They ask the person to do something and they don't want to. So people start to say that you know, there might be consequences, you know, as in if they ask someone if they'll go and have a shave, they'll start to say things like, well, your wife won't be happy with you if you don't have your shave before she comes. And that becomes this sort of idea that actually you're intimidating the person rather than listening to what the person actually is telling you. You see it a lot when people become so focused on the disease, they forget there's a person there. And you sometimes see it in mental health wards, you see it in general health wards, you see it in care settings, where people are referred to as they might be referred to as dementia. People do it in general health wards, refer people as diabetes, because the actual focus becomes the illness or the disease rather than the person. And in mental health wards, I've heard people use terms about, you know, things like how at lunchtime, people have said things like, you know, how many feeders have we got in today? Meaning how many people actually need help with feeding. And you realize then that that personhood is actually just disappearing because you're looking at the person in terms of their behavior rather than who they are. Now, all these things like the enhancers and detractions, they're all based around Kitwood's psychological model for people with dementia. And that model is something you might be familiar with, that we have attachment needs, that things that we're actually attached to, things that we feel close to. There's a need for comfort, that we want to feel psychologically comfortable, that we don't want to feel threatened or intimidated. There's issues around identity, that actually we all have different things that make us who we are. The occupation is not just what we did as an occupation or what we do, but also what is meaningful for us, what gives us purpose. And finally, inclusion is that idea that actually we're not stigmatized against, we're not in a place where we don't feel that we belong, and to make sure people actually feel like that. And the central theme for Kitwood was always this sense of love, that people, if you provided these things, that the basic human need is that sense that actually you are loved and you're actually wanted, and people aren't doing things for you simply because they feel they have to or they're going to get something out of it. So as that is our dementia co-mapping model that we used during this period of COVID, we looked at two wards. I'm sorry, I'll just go past it because we're running out of time to look at that. In terms of actually the two wards we looked at one ward that had an 80% population of people that were female with dementia. The mean age was 83. We had another ward, Ward B, that was 30% female. The mean age was 76. We did some scales. So the clinical dementia rating scale was similar in both places, and kind of said that people on those wards were people with kind of a moderate to severe dementia, and both cohorts scored highly with sort of the neuropsychiatric inventory for things like agitation. But this wasn't anything different to what we would see in that ward for pre-COVID cohorts. That's what those wards are. They are for people with dementia but needing some intensive assessments. Surprisingly so, in terms of actually our results, though, is what we saw was a good level of well-being. So in terms of our mood and engagement scores, our averages were around 2.5. So when you think about that +5 being the highest, an average of 2.5 is actually very good when you think that a neutral score, a kind of flat score, would be 1. So actually it was higher than what we were expecting. In terms of personal detractions, what we observed, we saw very few personal detractions during the observations, so much so we couldn't really do an analysis around those kind of detracting actions. In terms of personal enhancers, compared to the 5-year average, what you can see there, that they were kind of similar, the two wards, Ward A and Ward B, for the 5-year average was around 11 to 12. And actually, that 11 to 12 meant about 11 to 12 every few time frames. And then when you looked at the results we had this time, although it appears to have gone lower, the actual lower score is actually an improvement. The lower score you can get is the better score. So if you'd have scored a score of 1, that would actually mean that you actually saw enhancing actions every single time frame, while a score of 8 says we were seeing that every 8 time frames, which was an improvement on what we were seeing usually. But it was a case of almost like care had become slightly different. There was a new care as usual. And rather than covering the whole of that model of comfort, attachment, identity, Ward A seemed to prioritise comfort. And yes, people were dressed in all this PPE, and yes, there was social distancing, and yes, there was restrictions, but actually staff appeared to be much more sensitive to non-verbal communications. And, you know, there's been lots of studies that have suggested that staff are not quite not really that great at understanding non-verbal communications with people with dementia. But actually what this project showed was that people were actually more sensitive with it because they were actually having their faces covered. And what we saw was people almost acting as if they were on stage and delivering a kind of way of talking to each other in a different way. And what we saw was that the people living with dementia also reacted to that in the same way. And actually non-verbal gestures became much grander, and that provision of comfort could still be done. It could still be done in that, say, in a different way. Ward B, on the other hand, prioritised attachment and sort of acknowledged more that there was an absence of that close person, the fact that families couldn't visit, and they spent a lot more time validating the emotions of the person rather than just sticking rigidly to the sort of task-related care, which tended to sometimes dominate actions of caregivers. So yeah, we didn't see the whole model almost being covered, but at the same time, we could see how wards were reacting to this different world, and it was a new form of care as usual. So I guess there's implications there for mental health nursing. And I think what we found is that if you're adequately trained, you're supported, regulated, you can still provide care that actually does enhance well-being, even within the context of the pandemic. And I think that's a really key finding, simply because it's something that hasn't really been able to be looked at before, in terms of we kind of accept that things had changed, but we didn't really understand how, because we couldn't get in there, we couldn't really see what was happening. We saw that practitioners can adapt to restrictions. And it meant that, yeah, we saw things like comfort and attachment being given more, but actually that feedback to the staff was really important to say, we can see what you're doing and it's actually working. Because we have to be careful as well that sometimes this conversation that seems to be intuitively kind of, you know, things can't be as good because obviously we are socially distancing, we do have PPE, we're not having visitors, so things are not being as psychosocially as good as they were before. We have to be really careful that we don't just keep saying that, because that becomes this sort of nihilistic thing where actually we're saying to people who are trying to do these things as well that actually it's not working. So getting staff to have that feedback, that they understand what they're doing is that what they're doing that actually works, is really important. So we have to make sure that focus on physical care, which understandably is very important, doesn't mean it's to the detriment of holistic practice as well. Mental health nurses do have a professional responsibility to make sure, mental health wards are therapeutic environments, provides a holistic care. It's not acceptable to say we're in the middle of a pandemic and physical care is the priority. It's part and parcel of mental health nursing. But I think what the small studies sort of began to show that actually you can still do it within a pandemic. It's still possible to look at psychosocial care, and that DCM, dementia care mapping, it gives a framework for people to begin to understand what they're doing and how it's having that impact during this period of time. And dementia care mapping will continue to go on and be used after the pandemic like it was before. Like I say, it's a 30-year-old system that's very well evidence-based. But I think on this occasion, because there was that opportunity to actually use it as part of routine, which we never would have been able to do as a piece of just pure research, I think it's helped us to understand some of those things a little bit more. So thank you.